Hello, our dear students. Today we continue our cycle of lectures in Propaedeutics of Internal Medicine for third year students and included their submodule about GI disorders. And topic of our today's lecture it is syndromes of hepatobiliary tract and endocrine pancreas disorder. And today I want to pay more attention to one interesting syndrome that named jaundice. Plan of our today's lecture it is a spectrum of hepatobiliary tract and pancreas disorders. Yes, we're going to separately stop on hepatobiliary tract and exocrine pancreas. And I want to remind you on this picture the scheme of anatomy and try to remember physiology of hepatobiliary tract and pancreas function. Spectrum of hepatobiliary tract disorders. Yes, disease that is connected with bile duct and gallbladder. It is gallstones, it is stricture, it is leaks of bile caused from trauma and surgery, gallbladder cancer, bile duct cancer or cholangiocarcinoma, cholangitis and cholecystitis. Disorders connected with liver. About liver we will have a next lecture. There will be more information, but today we stop on some moments because it is one connected system. In liver, it is liver tumors or hepatocellular carcinoma, metastatic colorectal cancer, neuroendocrine cancer are the metastatic tumor. Benign liver lesions like hepatic cyst, hemangioma, adenoma, focal nodular hyperplasia. And fatty liver, hepatitis, and liver cirrhosis. It is the most often cases of liver disorders. Disorders that connected with pancreas. It is pancreatic cancer, it is acute and chronic pancreatitis, pseudocyst, and cystic neoplasms. Syndromes in hepatobiliary tract. Let's divide all disorders. It is a huge number of different diseases included there, but we can divide it in several syndromes. It is gallbladder motility disorder, it is jaundice, it is liver size changes, portal hypertension, hepatocellular dysfunction, and cholestatic syndrome. Some of these syndromes we're going to discuss today. And let's stop on gallbladder motility disorder. It is first syndrome from previous slides and give it definition. Gallbladder motility disorder is defined as biliary pain in the absence of gallstones, sludge, microlithiasis, or microcrystal disease. The diagnosis is considered in patients with typical biliary type pain who have had no other causes for the pain excluded. The prevalence of functional gallbladder disorder among patients with biliary type pain and normal transabdominal gallbladder ultrasound is up to 8% in men and 21% in women. Causes and mechanisms of gallbladder motility disorder. The cause of it is unclear. Usually it is a complex of several risk factors. It is generally regarded as motility disorder of gallbladder. It may result from initial metabolic disorder, including bile supersaturated with cholesterol, or a primary motility disorder in the absence or at least initially of any abnormalities of bile composition. It has been noted that patients with functional gallbladder disorder may have abnormal gastric emptying and colonic transit, suggesting a possible generalized gastrointestinal motility disorder. The hypothesis that disorder is related to abnormal gallbladder motility is the basis for measuring the gallbladder ejection fraction as part of the evaluation. Clinical symptoms of gallbladder motility disorders. Patients present with biliary type pain, also known as biliary colic. The liver and pancreas blood test usually normal in this case because it mostly functional disorder. Previous lecture I explained to you what is functional disorder. No gallstones or gallbladder sludge are seen on imaging and upper endoscopic examinations are normal. Despite the name, biliary colic is usually constant and not colicky. The classic description of an intense discomfort located in the right upper quadrant of epigastrium that may radiate to the back, particularly to the right shoulder blade. The pain is often associated with diaphoresis, nausea, and vomiting. The pain plateaus is less than an hour, ranging from moderate to excruciating in severity. The pain typically lasts at least 30 minutes and then slowly subsides over several hours, with entire attack usually lasting less than 6 hours. While the pain often develops 1 to 2 hours after ingestion of a fatty meal. And associated with meals is not universal, but in most patients it present. And in significant proportion of patients, the pain is nocturnal with a peak occurrence around midnight. While non-specific dyspeptic symptoms such as indigestion, abnormal bloating, and belching may coexist in patients with biliary colic, they are not usually relieved by cholecystectomy. Laboratory tests, imaging, and endoscopic studies. How to confirm diagnosis of gallbladder motility disorder with additional tests. Patients with functional gallbladder disorder have normal blood tests. In addition, abnormal imaging is normal, with no evidence of gallstones, gallbladder sludge, or cholesterol polyps. Finally, patients have normal upper endoscopic examinations. The criteria for biliary type pain, how to differ it from other types of abdominal pain. Usually for gallbladder motility disorder, pain is located in the epigastrium and or right upper quadrant. Pain is recurrent in such patients but occurs in variable intervals, not just daily. Pain lasts at least 30 minutes. Pain builds up to steady level. Pain, usually in gallbladder motility disorder, are severe enough to interrupt daily activities or lead an emergency department visit. Even such intensive pain can be in these patients. Pain is not relieved by bowel movements, postural changes, or antacids. Supportive criteria, it was the main criteria, and additionally to it we can check if the pain associated with nausea and vomiting, what is characteristic for gallbladder motility disorder. Pain radiates to the back or right infrasubscapular region, and pain awakens patient from a sleep in the middle of the night. Next syndrome for today that I promise you to stop more because it is very important, very often, and interesting syndrome. It is syndrome of jaundice. Jaundice, or from Latin icterus, it is a yellowish pigmentation of the skin. The conjunctival membranes over the sclera, whites of the eyes, and other mucous membranes caused by high blood bilirubin levels. Jaundice causes increased level of bilirubin in the extracellular fluid. A concentration more than 3 mg per deciliter leads to jaundice. It is a picture examples of jaundice. It usually starts from mucus and the most visible it usually in sclera. It is white part of eye, and even before skin coloration we can see some yellowish color of sclera, like in this picture. And one more time remind, it can be present when concentration of bilirubin more than 3 milligrams per deciliter or more than 50 millimoles per liter. Types of jaundice. It can be several types. It can be pre-hepatic jaundice, it can be intra-hepatic jaundice, and it can be post-hepatic jaundice. And a little bit other type, it is neonatal jaundice. Why I include here this picture? Because in all these types it will be a little bit different colors and subtypes of jaundice and different color of skin and mucus of our patients. Let's stop on each one. Pre-hepatic jaundice. Yes, pre-hepatic, hepatic, post-hepatic, and neonatal. Pre-hepatic or before liver. It is caused by anything which causes an increased rate of hemolysis. It is breakdown of red blood cells. What it can be? It usually severe malaria, sickle cell anemia, spherocytosis, thalassemia, pyruvate kinase deficiency, glucose 6-phosphatase dehydrogenase deficiency, diseases of kidney, defects in bilirubin metabolism, etc. are the more rare cases. The increased breakdown of red blood cells leads to increase in the amount of unconjugated bilirubin present in the blood, and deposition of this unconjugated bilirubin into various tissues can lead to a jaundiced appearance. In jaundice secondary to hemolysis, the increased production of bilirubin leads to increased production of urobilinogen. Bilirubin is not usually found in urine because unconjugated bilirubin in this case is not water-soluble. So the combination of increased urine urobilinogen with no bilirubin, since unconjugated is in urine, is suggestive for hemolytic jaundice. Yes, how to confirm specifically this type? Here one more time, it is scheme of pre-hepatic or hemolytic jaundice. According to a mechanism, we often name it hemolytic jaundice. Yes, it is breakdown of erythrocyte, and after breakdown it is increased level of conjugated bilirubin. Normally it must be conjugated in liver and removed through the GI, but when it is hemolysis, it is a very massive breakdown of a big number of erythrocytes and very rapid increasement of and big volume in one moment of unconjugated bilirubin. And liver, even in normal function, can't timely conjugated all this bilirubin. That's why it will be accumulation of unconjugated bilirubin, decreasement of conjugation and excretion of this bilirubin from organism, and it leads to prehepatic or hemolytic jaundice. Second type, it is intrahepatic. We go lower and problem in liver or intrahepatic jaundice. Intrahepatic jaundice can be caused by acute or chronic hepatitis, hepatotoxicity, for example, after using some drugs, due to cirrhosis, drug-induced hepatitis, inflammation, or alcoholic liver disease, leading to an increase in plasma conjugated bilirubin because there is impairment of excretion of conjugated bilirubin into the bile. The blood contains an abnormally raised amount of conjugated bilirubin and bile salts which are excreted in the urine. This conjugated bilirubin then return to the blood, probably by rupture of the congested bile canaliculi and direct emptying of the bile into the lymph, leaving the liver. Thus, most of the bilirubin in plasma becomes the conjugated type rather than the unconjugated type. And this conjugated bilirubin, which did not go to the intestine to become urobilinogen, gives the urine dark color. Here a scheme of intra-hepatic jaundice. Here you see that it is no abnormal breakdown of erythrocytes, always physiological number of physiological volume of unconjugated bilirubin go to the liver, but there is some problem, either cirrhosis or hepatitis or fatty or alcoholic liver disease or other liver problem that affected function of conjugation of bilirubin. Yes, and this physiological number of unconjugated bilirubin partially can't be conjugated at all, and partially it was conjugated, but according to damaging of hepatocytes, absent normal excretion of conjugated bilirubin, and both of them, as conjugated as unconjugated, are mostly conjugated, usually absorbed into the blood. And result you see, it is increased general bilirubin, increased conjugated, maybe increased unconjugated bilirubin, and urobilinogen and urobilin and dark color of urine. Post-hepatic jaundice, it is third types. We go lower when the problem it goes after the liver. Post-hepatic, or another name, obstructive jaundice. It is caused by interruption to the damage of bile containing conjugated bilirubin in the biliary system. The most common causes are gallstones in the common bile duct and pancreatic cancer in the head of the pancreas. A group of parasites like liver flax can live in the common bile duct, causing obstructive jaundice too. Other causes include strictures of the common bile duct, biliary atresia, cholangiocarcinoma, pancreatitis, cholestasis of pregnancy, and pancreatic pseudocysts. Incomplete obstruction of the bile duct, no urobilinogen is found in the urine. Since bilirubin has no access in the intestine, and it is in the intestine that bilirubin gets converted to urobilinogen to be later released in the general circulation. Presence of bilirubin conjugated in the urine without urine urobilinogen suggests obstructive jaundice, either intrahepatic or posthepatic. The presence of pale stools and dark urine suggests an obstructive or post-hepatic cause of jaundice. Patients can also present with elevated serum cholesterol and often complain of severe itching or pruritus because of the deposition of bile salt in the skin. And scheme of post-hepatic jaundice. Yes, we have normal breakdown and normal destruction of erythrocytes. Unconjugated bilirubin go to the liver. There, the function of liver is absolutely normal. It's okay. It goes physiological process of conjugation, and after with the bile, it goes to bile ducts, and there we have some problem. There we have some obstruction. Yes, and this bile with conjugated bilirubin can't goes normally to the GI, and it can be stopped in the liver and can be absorbed into the blood and into the lymph with all results. Yes, it is darkening of urine, pale stool, and different laboratory changes that we said earlier. And fourth type, it is neonatal jaundice. It is connected with the age and with the newborns. Neonatal jaundice is usually harmless and often seen in infants around the second day after birth. lasting until day 8 in normal birth or to around day 14 in premature birth. Typical cases of neonatal jaundice include normal physiologic jaundice, jaundice due to formula supplementation, and hemolytic disorders. Serum bilirubin in this case normally drops to a low level without any intervention required. In cases where bilirubin rises higher, a brain-damaging condition known as kernicterus can occur, leading to significant disability. A bilirubin is often the tool used in early treatment, which often consists of exposing the baby to the intensive phototherapy. Yes, here you see pictures of newborns with jaundice. Left picture, it is second, third day newborn. You see that skin become a little bit yellowish, and after phototherapy you see that it is absolutely normal color of this baby. Symptoms of jaundice: a yellowish discoloration of the white area of the eye and the skin. The conjunctiva of eye is one of the first tissues to change color as bilirubin levels rise in jaundice. Urine, depending on type, can be dark in color. Stools, feces or poo can be pale in color. And one more picture, it is the same patients with normal, earlier with normal color and with yellow coloration on jaundice. Diagnostic tests that we can use for jaundice. And let's discuss differential diagnosis between three main types, that is prehepatic, hepatic, posthepatic. Accordingly, preliminary, we can define what type according to symptoms. Yes, is it present coloration of urine, discoloration of stool, what type, subtype of color of skin, other clinical symptoms. We can suppose what type, but we can confirm it just with laboratory studies. What laboratory studies we use for diagnosis of jaundice? First, it is total bilirubin. Total bilirubin in prehepatic can be normal or increased. In other types, it always increased. It is fractions, conjugated and unconjugated bilirubin. Conjugated will be normal just in prehepatic, and in hepatic and posthepatic it will be always increased. Unconjugated bilirubin, it can be normal or increased. In prehepatic it will be always increased in hepatic type and normal in posthepatic type. Urobilinogen will be normal or increased in prehepatic, decreased in hepatic, and decreased or negative in posthepatic type. Urine color will be normal in prehepatic and dark in hepatic and posthepatic due to conjugated bilirubin, you remember. Stool color normal in prehepatic, in hepatic can be normal or pale according to level of conjugated bilirubin, and in posthepatic in obstructive type is always pale. Alanine aminotransferate and aspartate aminotransferate, or LT-AST. They usually normal in prehepatic type and will be always increased in hepatic and posthepatic types of jaundice. The same with alkaline phosphatase level. It will be normal just in prehepatic. What about conjugated bilirubin in urine? It will be not present in prehepatic. You remember they are just unconjugated bilirubin, and it usually positive. It is present in hepatic and posthepatic type. And presence of splenomegaly, it usually present in prehepatic, often in most cases present in hepatic time, but in obstructive time it will be no splenomegaly in patients. Syndromes of liver size changes. Yes, it is enlarged liver or hepatomegaly, and small size of liver, the opposite situation. Enlarged liver causes: it is alcoholic liver disease, it is congestive heart failure, cirrhosis of liver, hepatitis, liver cancer, hyperlipidemias, hepatic vein thrombosis or Bad-Chiari syndrome, metabolic syndrome X, pericarditis, adult onset Still's disease, hypolipoproteinemia, and a huge number of other causes. Symptoms of enlarged liver: it is feeling of fullness, it is discomfort in the belly, it is depending on cause of enlarged liver. Patient may notice symptoms like jaundice, fatigue and weakness, nausea, weight loss. For diagnosis of enlarged liver, you can do physical examination, and with teacher you will be obligated to pay attention to this examination. It is palpation and percussion of liver. Yes, very important, really useful in real clinic objective physical methods, and because please be attentive in the classes, and please practice with your practical class teacher, and please practice them this palpation and percussion at home in each other to check liver sizes and liver position. To confirmation of enlarged liver, we use CT scan, MRI or ultrasound investigation. Physical examination. Yes, first picture I remind you normal position of liver. Yes, it is subcostal position, and normally liver margin during palpation it's not lower than ribs margin. Yes, and second picture, it is a patient with enlarged liver, and after palpation and percussion by the pen, doctor visualize size and position of liver, and you see that in this patient it is much more lower position of liver than physiological. It is much more lower than ribs. That's why just after physical examination, very rapid and very simple test, we are sure that here is present significant liver enlargement. CT scan. Yes, here you see a native CT scan that shows slightly lobulated liver contour with ascites and dilated bile ducts and an enlarged spleen. Yes, we confirm all information, a lot of information that we can find during physical examination. As hepatomegaly, as splenomegaly, as ascites, we can find by our percussion and palpation. It is MRI, and here very significant hepatomegaly. You see the picture, the middle gray color, it is all liver, it is huge, it takes nearly all abdominal cavity, and additionally it is multiple hypoechogenic areas in the spleen, suggesting splenic involvement. Ultrasound methods. It is very informative too. A lot of information, sizes, position, structure of parenchyma we can get from ultrasound. In this case, you see Hodgkin's disease with splenomegaly, hepatomegaly, and enlarged mesenteric lymph nodes. And opposite situation, it is small size syndrome for liver. Yes, it is decreasement of size of the liver. Small size syndrome is condition which causes considerable confusion, partly because the term has been extended beyond its original meaning. It was initially used to describe the situation in the liver transplantation, where a patient develops liver dysfunction and ascites because the donated organ is too small for the recipient. Small size syndrome, it is condition which causes considerable confusion, partly because the term has been extended beyond its original meaning. It is now used variably and describes any circumstances which is a post-operative liver failure or dysfunction in patient who has had liver resection or partial or small graft liver transplantation. Okay, here you see scheme of liver transplantation. Yes, it is taking of some lobes and transplantation it from the donor to recipient. And as donor, as recipient has a risk of small size syndrome and liver failure, especially recipient. It depending on volume of transplantation. Mechanisms of small for size syndrome. Small for size syndrome can occur in special situation of partial liver graft transplantation, especially in adults living donor liver transplantation with resultant size mismatching between graft size and recipient hepatoportal circulation. Once the partial liver volume graft is subjected to excessive portal inflow, portal hyperperfusion results in the development of the small for size syndrome. Symptoms. It is excessive ascites, hyperbilirubinemia, coagulopathy, encephalopathy, and renal dysfunction. Transplant recipients develop symptoms related to the above abnormalities after transplantation, and post-transplant prognosis is reported to be less than ideal. It is a little bit worse, but it's all curable. Next syndrome for today is portal hypertension. Portal hypertension is abnormally high blood pressure in the portal vein system, which is composed of the portal vein and its branches and tributaries. Portal hypertension is defined as elevation of hepatic venous pressure gradient more than 5 mm Hg. Causes. It is prehepatic portal vein thrombosis or congenital atresia. It can be intrahepatic liver cirrhosis, hepatic fibrosis, non-cirrhotic causes like schistosomosis, massive fatty changes, and diffuse granulomatous disease. And post-hepatic, hepatic vein thrombosis, inferior vena cava thrombosis, inferior vena cava congenital malformation, and constrictive pericarditis. Please pay attention that as jaundice as portal hypertension has 3 types: prehepatic, hepatic, and post-hepatic. But if in jaundice we goes from the up to down, yes, it is level of problem in blood with destruction of erythrocyte and hemolysis. After it lower, it is liver. After it lower, it is obstruction of bile ducts. Here it is the opposite. Prehepatic, it is lower, problem in portal vein. After it upper, hepatic, it is problem in with the liver structure, and post-hepatic, it is even upper. It is problem with veins, with vena cava inferior or other veins, or liver vein, hepatic vein, or other vein system problems upper than liver, portal liver veins. Symptoms of portal hypertension. It usually weakness, tiredness, and malaise. In several cases, it can be anorexia and weight loss, common with acute and chronic liver disease. It can be ascites, it can be hepatic encephalopathy, increased risk of spontaneous bacterial peritonitis, increased risk of hepatorenal syndrome. Moreover, splenomegaly with consequent accumulation of red blood cells, white blood cells, and platelets together leading to mild pancytopenia. Development of varices at portocaval anastomosis. It is esophageal varices, gastric varices, anorectal varices, caput medusa. Esophageal and gastric varices pose an ongoing risk of life-threatening bleeding with bloody vomiting or blood in the stool. One more time, schematically, symptoms of portal hypertension. Yes, according to liver insufficiency, it will be hepatic encephalopathy. It can be malnutrition, skin spindle angiomata, esophageal varices, portal. According to varices in system of portal and splenic vein. It can be splenomegaly. It can be periumbilical caput medusa because it is increased vein due to varices. It can be hemorrhoids. It is varices too, and testicular atrophy. Symptoms of ascites include accumulation of fluid in lungs, in liver. It can be affected stomach. It can be peritoneal space containing bowel. It can be peritoneal edema of peritoneal membranes. It can be peritoneal effusion, or we name it ascites, and it is edema and fluid in pelvic organs. It is the symptoms that we name caput medusa. Yes, you see the enlarged veins and visible veins around in paraumbilical space that look like medusa. Diagnostics of portal hypertension. It is clinical syndromes. It is tests that we name HVPG, or hepatic venous pressure gradient measurement, as the gold standard for assessing of severity of portal hypertension. It replaced the old one, the contrast angiography. Portal hypertension is defined as hepatic venous pressure gradient greater than or equal to 5 mm Hg and is considered to be clinically significant when HVPG exceeds from 10 to 12 mm Hg. Additionally, we use imaging tests to confirm mainly causes of portal hypertension. For hepatic types, we always use liver biopsy and histological examination of these pieces. It is hemodynamic measurement of hepatic venous pressure gradient and upper GI endoscopy or esophagogastroduodenoscopy. It is a criterion standard for assessment of portal hypertension. Here we see measurement of hepatic venous pressure gradient. It is measured or ultrasound measurement of damping index (DI) and hepatic vein waveform. A patient with liver cirrhosis showed 0.26 of DI with 7 mm Hg of HVPG. And picture B, it is patient with liver cirrhosis showed 0.72 NDI and 15, a very great HVPG millimeters Hg. Additionally, we talk about visualization. Here the most informative it is MRI, and in this MRI picture we see coronal section plane of the abdomen acquired with the true fast imaging sequence used to define the middle segment of portal vein. And upper endoscopy or esophagogastroduodenoscopy. Here you see endoscopic view of multiple large portal hypertensive polyps in the antrum. Laboratory tests for portal hypertension. It is CBC. It is liver function tests, including ALT and AST and bilirubin and all its fractures. Obligatory, it is coagulation studies like prothrombin time, partial thromboplastin time, international normalized ratio. It is blood urea nitrogen, creatinine, and electrolytes. It is arterial, blast, gas, and pH measurements to exclude or confirm acidosis. Moreover, we can use hepatic and viral hepatitis serology, particularly hepatitis B and C serology if we suspect them. We check albumin levels for because hypoalbuminemia is common situation in portal hypertension. We check anti-nuclear antibody, anti-mitochondrial antibodies, and anti-smooth muscle antibodies to exclude different systemic connective tissues or autoimmune disorders. We check iron indices, we check alpha-1 antitrypsin deficiency, and we should check ceruloplasmin and 24-hour urinary copper. And syndromes of disorders of exocrine pancreas. You remember that pancreas have as endocrine as endocrine functions. Yes, endocrine functions we will discuss several lectures later. It will be endocrine lecture about diabetes mellitus. And today we are going to discuss the endocrine function of pancreas that have a very significant role in our gastrointestinal function. Endocrine pancreas insufficiency usually goes with diarrhea, steatorrhea, abdominal pain, and symptoms of vitamin deficiencies. Definition of exocrine pancreatic insufficiency. Exocrine pancreatic insufficiency is inability to properly digest food due to a lack of digestive enzymes made by pancreas. EPI is caused by progressive loss of the pancreatic cells and make digestive enzymes. Causes of exocrine pancreas insufficiency. They can be pancreatic and non-pancreatic. Pancreatic causes include chronic pancreatitis the most often. It can be cystic fibrosis. It can be obstructions of the pancreatic duct. It can be Schaumann-Diamond syndrome. It is exocrine pancreatic insufficiency, bone marrow dysfunction, leukemia predisposition, and skeletal abnormalities. Non-pancreatic causes of endocrine pancreas insufficiency include celiac disease. You remember previous lectures. It is Crohn's disease. It is autoimmune pancreatitis, Zollinger-Ellison syndrome, GI and pancreatic surgical procedures. Yes, post-surgical complications. Exocrine pancreatic insufficiency pathophysiology. It characterized by a deficiency of exocrine pancreatic enzymes, which result in inability to digest food properly. We name it maldigestion. A lot of information in the previous lecture. Because pancreatic lipase accounts for up to 90% of fat digestion, maldigestion of fat is more profound in exocrine pancreatic insufficiency than maldigestion of proteins and carbohydrates. Fat digestion is not clearly impaired until lipase output decreases to below 10% of the normal level. Fat malabsorption precedes malabsorption of other macronutrients. Bile salt precipitation and subsequent absorption to undigested food reduce the bile salt pool, and this reduction further impairs fat digestion. Undigested fat, rather than being absorbed, is excreted in the feces, leading to steatorrhea. Another factor that contributed to pancreatic steatorrhea is the presence of neurohormonal disturbances, which result in gallbladder hypomotility and accelerated gastric and intestinal transit. Malabsorption of fat-soluble vitamins A, D, E, and K may accompany EPI. Symptoms of exocrine pancreatic insufficiency or EPI. It is steatorrhea, it is weight loss, diarrhea, it can be pale, bulky, malodorous stool, often float on top of the toilet water with oily droplet and are difficult to flush. And it can be fatigue. Additionally, we can find in patients flatulence and abdominal distension. It can be edema as a result of hypoalbuminemia. It can be anemia, can be either microcytic related to iron deficiency or macrocytic related to vitamin B12 deficiency. It can be bleeding disorders, a consequence of vitamin K malabsorption and subsequent hypoprothrombinemia. It can be ecchymosis on the skin, metabolic bone disease due to vitamin D deficiency. It can be neurological manifestations like generalized motor weakness, peripheral neuropathy, loss of sense of vibration and position, night blindness, seizures. Diagnostic of exocrine pancreatic insufficiency. We usually use blood test, 3-day fecal test, fecal elastase 1 test, and visualization. It is CT scan, MRI, and endoscopic ultrasound. What is 3-day fecal test? The normal range for fecal fat testing in 7 grams over a 24-hour period. Normal result for 72-hour test would be 21 gram. Why we don't check it during day? Because it's not informative according to diet, according to activity of the patient, according to frequency of stool of the patient. We can't get informative result during one day. That's why we usually use 3 days test. Fecal elastase 1. Reference concentration to interpretate pancreatic elastase results after the first month of life. If it more than 200 milligrams elastase per gram stool, normal exocrine pancreatic function. If we find from 100 to 200 till 200 milligrams elastase per gram stool, it is mild to moderate pancreatic insufficiency. If it is less than 100 milligrams elastase per gram of stool, indicates it confirms endocrine pancreatic insufficiency. We use such tests and such buffers for this test, as you see on this picture. Okay, for today that's all. It is the main things that I'm going to discuss with you today. If you have questions, if you have comments, if you want to discuss something, I will be waiting for us in our Facebook page under this lecture in comments, and as usual in comments under this video on YouTube, I ask everyone who listens this lecture to write your name and your group. For today that's all, and see you next lecture. Goodbye.